Thank you all so much for attending our live webinar today, and greetings to all of those who registered for the recording and those that are viewing this in the near future. My name is Colby Dix, and I'll be your moderator for the presentation. A few brief points that we'd like to make up front. We will be making the slide deck and a link to the webinar recording available shortly after the webinar to all of our registrants. So don't worry if you missed something initially. You'll get this in a follow-up. Today's webinar, Next Generation Technologies and How They Drive ACO Performance, will be presented by Mark Anderson, whom I will introduce shortly. The presentation will be followed by a Q&A in which we will do our best to answer all of your questions. And rest assured, if we can't get to you within the allotted time, we'll follow up directly after the presentation. And after the Q&A with Mark, there'll be a brief presentation by our sponsor, Care360, highlighting their full suite of integrated healthcare IT offerings that perform wonderfully with the new ACO VBR model. As well, we will offer up a second short Q&A to answer any questions that you may have about Care360 or other IT integration concerns. To ask a question today, we invite you to use the WebEx built-in Q&A functionality. If you are in windowed mode, there's a button to your top right that reveals the Q&A box in the right column. And if you're in full screen mode, that button is at the top of your screen within the drop-down menu. I'd like to extend a warm welcome to our presenter today, Mark Anderson. Mark's bio is up on the screen now, and you can see that we're very lucky to have someone with such experience available to us. His 40-plus years of dedication to healthcare IT and consulting has earned him a great renown in our industry. Welcome, Mark Anderson.
Well, thank you very much for allowing me to connect in with everybody on the call today. We're going to be talking really about accountable care organizations and what kind of new technologies are going to be required for ACOs and for physician offices to be able to tie it in, to be able to get everything really working together in a seamless manner as we move towards what we're calling value-based reimbursement. And we'll talk about that as we go through the slides. Next slide. So the question today are going to be, are ACOs really improving quality while reducing cost, which is one of the things that ACOs were supposed to do, is improve quality and reduce cost. But why is the payment system changing? And as we'll see as we go forward, in 2018, we're going to see a big change in how physicians get reimbursed. But what is value-based reimbursement? We're going to talk about that, kind of explain it in case you have not heard of it before. Some people call it population health. We're really going to explain exactly what that is. But what do you need for value-based reimbursement? What kind of technologies are going to be required? What are you going to have to do to thrive in this market? And with the proposed changes to reimbursement, will you need new technology solutions more than you have today? Yes, you got meaningful use stuff out there that you've gone through meaningful use stage 1 and 2, but value-based reimbursement is totally different from the basic requirements of meaningful use. And what are those software needs we're going to talk about? And where is the real value in exchanging data within a community? When the HITECH Act came out, the whole idea was to exchange information between the general physician, the general practice, primary care, and the cardiologist, and the neurologist, and the hospitals. But we've not really got to that area where we're actually able to exchange a lot of data so far. But there's a lot of value in that. And then we're going to end on what you should do next to prepare for value-based reimbursement and the changes that may affect a big portion of your income as you go forward.
All right, so we're going to dive right in here in question 1, Mark. Now, obviously, there's plenty of hype around the ACO model, but are ACOs actually improving quality while reducing costs?
Well, it really does depend on the ACO and the model they've done, but let's look at a few of the statistics that are out there today. So you've got about 24% of the established ACOs that are out there that have actually earned the shared savings bonus. That means that they are meeting the requirements, they're improving quality, and they're getting the bonuses that come out of the Medicare program. 27% are reducing spending, but not enough to actually earn the bonuses. So you kind of look at that as about 51% overall are at least cutting some of the costs down, but not necessarily improving the quality to be able to get the bonuses. 46% did not achieve any savings out there at all. And another 3% achieved some savings but not successfully report the information. The question is, why did the 24% improve and get the bonuses, but 46% got absolutely nothing? They did not get any savings and not improve the quality. That is a big question that's out there today. Next slide. And one of the big reasons for a lot of this is the changing of our approach for getting reimbursed and what you have to do. The ACO model is really built around the 2020 reimbursement model, where fee-for-service really goes down. It goes from 80% in 2010 down to less than 20% in 2020. It's all about managing the population, looking at what we call full population care, partial population care, basically taking care of the people that have chronic diseases, reducing their overall costs and improving quality. The challenge we find with a lot of the ACOs that did not get the bonuses is that they were still running their organization as a fee-for-service organization. It's all about improving quality on a specific patients that have chronic diseases and reducing costs. The ones that did get the bonuses were running it as a true partial population health or full population health care, where they're actually working with chronic disease patients, analyzing all of the data, no matter where that patient goes, in the hospital, the doctor's office, home care, emergency room. All that data is together in one place, and they're analyzing what's going on. The ACOs that are not meeting the requirements typically still have a physician-oriented system and a hospital-oriented system, but not able to bring all the data together to look at care coordination throughout what they have to do for that population. Next slide.
So why then is the payment system changing, Mark?
Well, let's look at a few examples of why we're changing. Everybody's been talking about the cost that's out there, how much money we're spending. And on the next slide, first thing I should really talk about is we're still buried in paperwork. We've been talking about going electronic with everything, but so much of the work is still paper-based because we have not integrated in the inpatient side, the physician side, and all the other care areas, let's say home health, long-term care, rehab, the ambulance services. We're still pretty much paper-based when we look at everything, and we got to get away from that. We are buried in paper. The second thing is I started to talk, which is the next slide, is really looking at our spending. United States is 2 times higher in costs for the same type of health care than any other nation that's out there. So you're looking at Norway and the Netherlands. A lot of people talk about that have been really looking at how they manage the cost of a population, looking at how we keep people healthier. They're incentivized, the doctors in the hospital are incentivized to improve quality. They're not reimbursed based on fee for service. It's based on quality improvement. United States, we're still 80 to 85 to 90%, depending on the organization, fee for service. We don't have the incentives to keep people healthy because the sicker you are, the more money the hospitals make when you have to come into the hospitals. So we're trying to change that. We're saying we need to change this and really go after quality and create incentives for hospitals and doctors and our whole healthcare system to improve quality overall. Next slide. And if you go back and look at all the stuff that's come out of the studies the last, really 10 years, we are really far behind on making sure that our patients and the doctors are able to adhere to the quality indicators. Now, breast cancer and prenatal care and low back pain seem to be some of the best out there, but we're still at 75% or lower. But you start looking at alcohol dependency, hip fractures, urinary tract infections, diabetic type issues. We are under 50% of care plans, what should be done for the patients that people have agreed to, that are not meeting the requirements that are out there. We are not keeping patients on care plans that are supposed to keep them healthy. Overall, we're at 54.9%, and people with chronic care, people with diabetes, CHF, asthma, obesity, only 56% of those patients that have one of these chronic diseases are following the care plans. So that can be a combination of the patient not being compliant, or it could be a part of the doctors really not understanding all the care plans that are out there. What are the best practices for taking care of these types of patients? We got to get that information to the physician at the point of care and work with the patient and their families to make sure the patients follow the protocols to help them stay, let's call it somewhat healthier. Of course, if you're a patient with chronic care, you're probably not going to get healthy, but we can help manage that chronic care to help reduce costs and improve quality overall. Next slide. And why is it urgency? Well, we've been looking at the overall cost. how much money we've been spending on healthcare. That's the blue lines there that you see in front of you. But then the national health expenditures as a percentage of gross domestic product is increasing dramatically. And you start looking at how high we're up. Right now, we're looking at spending $4,300 per person out there, and how much money that we're actually looking at. Just a tremendous increase. We have to find a way of slowing the increase down. The interesting part is when we kicked in 2009, we went to the High-Tech Act and the ACA type thing, we really skyrocketed. You see that graph going up between 2008 and 2009. But we are spending so much money on healthcare today, and it's going to keep increasing. We have to cut that back. Most countries are less than 15% of the gross national product is spent on healthcare. We are just, look how fast we're going up. We cannot contain this type of rate increases for healthcare expenditures. We have to do something to slow it down. Next slide. And one of the questions always is, where does most of the money go? Well, right now, obviously 30.5% of all the money spent goes into the hospital side, really the inpatient side of the hospital business. You also have physician and clinical services, which is 20.3%. Other healthcare spending, that's on a lot of different things, including home care, not home care, but long-term care, rehab service, and things like that. So there's a lot of other kind of services that are still out there. But we got to really work on cutting down that 30.5%. We know from all the statistics that are out there, if I can get a diabetic patient to reduce one ER visit per year, I can pay for about 12 more office visits. So we're trying to move the care away from the inpatient side, keep them healthier, keep them out of the emergency room, and have them have more interactions with the physicians, or more movement towards patient engagement or family engagement, where a care coordinator is talking to the patient, finding out what's going on, how are they feeling. One of the examples we always bring up is a diabetic patient. Studies have shown that the diabetic patient gains 2 pounds from the morning to the next morning. So they gain 2 pounds from Monday to Tuesday. There's a 75% chance they're going to have an emergency room visit within the next 5 days. So if we can find a way of tracking a diabetic patient's weight on a daily basis, having that information come into a care coordinator where they can look at this data and see, oh, they've gained 2 pounds, then having the care coordinator call that patient or their family to find out what's going on. Did they just have a big meal the night before? What's the change? What happened? And maybe get them set up for an office visit to come back in and monitor some of their vital signs. If we could cut out one emergency room visit, it's more than going to pay for anything else that goes on with that patient for the rest of the year. So it's all about looking what's going on, creating good care plans, monitoring that care plan, and potentially reducing some of the overall healthcare costs as we go through. And again, obviously improving quality at the same time.
Well, Mark, let's take a tiny step back here and just go ahead and help to redefine the value-based reimbursement model a bit. And could you give us a deeper explanation of that, please?
Yeah, if you really look at when accountable care organizations really got going, back in the early 2000s, and 2009 seemed to be kind of the big kickoff, it's all about moving accountable care to patients that have chronic diseases. And Medicare started doing this, and they identified diabetes, CHF, asthma, obesity as some of the areas they really want to look at. It did not include cancer, but I think that'll be added on in the next couple of years. But it's basically the stuff that we can really, they believe they can manage. And to help organizations figure out how to do this better, they set up these accountable care organizations, also known as ACOs, with guidelines on you get a specific number of patients. For example, XYZ health system would get 3,000 patients assigned to them that had diabetes, and it was up to them to manage that care of that person. Come up with the best models for this. What is the best care provided? How do we improve quality and reduce costs? And they were going to receive, payments based on quality improvement, improve outcomes, and reducing the overall cost of care for those patients. And again, as I mentioned, it only included people with chronic conditions. So it wasn't people that were somewhat healthy. You had to have a designated chronic disease, being a Medicare patient, enroll into that model. And since then, the Blue Crosses, the Aetnas, the Cignas have also added new programs for these ACOs to manage their populations at the same time. So it's all about measuring quality and cost for people with specific chronic conditions. That's all it's based on today. And it's really kind of built around this, they call it triple aim, which is really trying to engage communities, getting everybody understanding who are the patients that are out there. How do you identify those things? How do you get what they call community resource navigators to find who these patients are and getting them involved in these kind of programs? And obviously you got to work on is getting those patients engaged. You got to create goals for that patient. You got to focus on coordination and continual care, continual improvement, and continual contact with the care providers and the patients. Part of it could just be improving access to care. A lot of times the patients, want to come in to get a visit, but they can't get that visit because it's a 2 or 3 week delay before they can come in. We're trying to make it so when there's an issue, people are talking to them and they're getting access to care either by the phone or by office visits with the physicians. And the third part, obviously, is now they got the community involved, they got the patient involved, and their family involved. It comes back down to how do we identify and reduce waste. There's about 17% of all tests that are run are really duplicated tests. Somebody's already ordered the test and got the result. The patient goes to a different doctor. That doctor doesn't have the result. They have to order it again. So if we can cut down those duplicate tests, we can cut out 17% of ancillary diagnostic tests that are already been done once with a patient. We need to find a way of sharing those results. And really try to improve screening and prevention that's out there. There's a lot of things we can do with people with chronic diseases to make sure they're not going to a new level. You may have somebody that's a diabetic patient, but maybe they don't have obesity problems, maybe they don't have CHF. But we got to find ways of improving the screening, doing more evaluations to keep them from going into comorbidity type problems that really do raise the costs out there. And obviously, the first thing you really got to do is we got to align the incentives to drive value, to really find ways of doctors and hospitals will pay you to help make sure this patient stays out of the hospital, keeps them healthier, improves the overall outcomes and quality of that person's life. You can't keep paying everybody when somebody's sick, which is how we get paid today. We got to find ways of keeping them healthier so that they don't get sick for the future. And that's what we're seeing in other countries, especially the Scandinavian countries, where the whole healthcare systems have been developed around keeping people healthy. So we got to work to that aim too. That's what I call it the triple aim, getting all three of these all tied together. Next slide. And, again, one of the issues ends up being is we have more and more patients getting on some kind of issue that drives a chronic condition. As I mentioned, obesity, diabetes, depression, a lot of stuff dealing with behavioral health and mental disorders are going out there, cardiovascular disease. So there's a lot of things. But we start looking at, from 2000, we had 125 million patients have a chronic disease. By 2030, we're looking at 171 million people with a chronic disease. It's very interesting because you go back and look at other countries. You start looking at their population. What percentage of their population has a chronic disease? The United States, we're at 38%. The Scandinavian countries are about 11%. So why do we have so many more patients with chronic diseases than other countries? It could just be how we eat, our habits, could be family type of conditions, things like that, where we can find ways of at least managing something or keeping the patient out of chronic disease, especially young children. We're finding a higher percentage of kids that have obesity today. They weigh a lot more than they ever did, partly because of the way we eat, and we've cut out a lot of the sporting activities by having people on the computers all the time. But, the obesity is going there. A young person that is obese is going to have diabetes in the near future if they don't control it. They'll have cardiovascular disease. They're going to have a lot of issues out there. We've got to start managing this today, especially with young kids in younger than elementary school and all the way through high school. We've got to find ways of monitoring those patients to help cut down this increase in the number of people with chronic diseases. Next slide. And as I mentioned, we're really changing to from this value-based reimbursement model, or that's what we're going to, for the fee-for-service. So back in 1995, it was less than 2 or 3% of our money came from value-based reimbursement, being paid for quality, not being paid for services. And it's been pretty steady. In 2015, we're about 4 or 5%. It's up to 8%, I think, right now as far as 2016. But we're looking at moving towards almost 50% of all of our reimbursements going to come from value-based quality outcomes and away from fee-for-service by 2018. Now, Medicare has already committed to having 50% of all of the payments tied to this value-based reimbursement model in 2018. Now, that really means for all the physicians out there, that starts in October 1st of 2017. That's when Medicare's fiscal year starts, that they're going to move 50% of all the payments towards one of these kind of new value-based models. And that could mean if you're not participating in one of these value-based contracts, you can lose 50% of all of your Medicare business as early as October of 2017. The other healthcare plans, United, Blue Cross, Aetna, Cigna, have all committed to getting 50% of their money moved towards this too. But their comments is sometime in 2018. We believe it's more going to be, maybe 5, 10, 15% in 2018. But we don't think they're actually going to hit the 50% model to probably 2020. But no matter what, we're talking about a movement away from your current reimbursement model, getting paid for seeing patients, towards changing how you get paid, what you get paid, and who pays you is all going to be changing starting in 2018. Enough where it could affect up to 50% of all the money you get paid today may go away. You may not be able to see these patients because these patients are going to be assigned to a specific health system and the doctors that they select to work with. And they may or may not select to work with you, which could affect your reimbursement tremendously. Next slide.
That's definitely a pretty daunting stat right there, thinking of just a little over a year away that we could be shifting that dramatically away, certainly on the Medicaid side. In light of that, what do we need to do ahead of time? What do we need to prepare for a value-based reimbursement system?
Well, what you're seeing out there right now is a lot of the big hospital systems, health systems as I call them, are hiring and employing more primary care physicians. And they're looking at how those primary care physicians could provide comprehensive, preventive, and chronic care to those patients, and then tie them into specific specialists that are out there. So for the average physician that's out there today, if you're a primary care physician, you're probably being asked by the hospitals, would you like to join our healthcare system as an employee? But 87% of the doctors out there still want to stay independent. They don't want to be an employee of a hospital, since the hospitals are gigantic brick walls, which is just a place where a doctor works. The doctor works in the hospital in their physician office. A lot of doctors don't want to be employed by the hospital, but we're seeing a lot of that going on today. More and more hospitals employing doctors to be part of their physician profile that's out there. But we're also looking at how they can restructure physician compensation to align the provider incentives with this value-based care. You're no longer, your salary may be $100,000 a year instead of making $200,000 a year, and your extra $100,000 is going to be tied to quality improvement things that doctors have not had to really worry about as much when it comes to statistical calculations of how somebody measures quality. It's much harder for the physicians to understand this because it's a totally different model that they have not really worked with since they got out of medical school. But they're also trying to find ways of creating patient-centered medical homes for building the blocks for the ACOs, getting the primary care physicians tied in with the specialists, with the family and the patient, creating this kind of, it's like say the medical home where we're actually looking at creating something that brings everything together so we can coordinate the care of the family, the patient, and all the doctors together. And obviously they're going to be spending a lot of their time on focusing on the care management of those high-risk patients. So you may have 500 patients that are diabetic, but which ones have the highest risk of cost and lack of quality improvement? So we got to do risk stratification of these patients to figure out who is the patient that has the worst conditions that are out there that have the best opportunity for improvement. They're going to be looking at all these statistics out there. So we're going from taking care of the patient to looking at all these statistical models to figure out who are the high-risk patients to take care of them first. because it's all about cutting costs and improving quality. The high-risk patients have the highest cost, sometimes 10 times higher than the average person with a chronic disease, and they have the highest risk of not improving the quality. So we look at those patients first. But obviously we have to find ways of automating all of this, identifying who the population is, identifying who those high-risk patients are, staying in contact with them. We have to automate this whole system. We cannot have a primary care doctor on one EHR and a specialist on a different EHR and the hospital on a different EHR not sharing of the information. You don't all have to be on the same product, but we have to be able to share the information seamlessly throughout the whole enterprise so that the care managers can really work with those patients and create this really close relationship with the patient and their family to understand what's going on with the patient today. Not in 3 weeks when they have an office visit or in 3 months for a preventive checkup. I need to know what's going on with these patients on a daily basis to help reduce costs and improve quality. We need to connect everybody together and share that information about the patient. Next question.
Excellent. Well, with those proposed changes to reimbursement, this seems like a fairly obvious question you're going to get some answers to here, but will you need new or additional technology solutions? I know even just the way you're speaking about having a daily update as far as where your patients are at would require a bit more depth in terms of our patient portals and the way that things are working, but what else is necessary?
Well, obviously the simple question answer is going to be yeah, we're going to have something totally new. The software products today have been built around fee-for-service billing, E&M coding, so we can basically code correctly so we can get the highest reimbursement. Under this model, a healthcare system is going to get paid, as an example, $8,000 per diabetic patient. That money comes in, and then it's up to the hospital how they pay for all that. We're not going to be sending bills out to insurance plans for these patients because there is no billing going forward with this. It's all about cost. You have to have a cost accounting system to understand what your costs are, understand everything about it. How do I understand what's going on with this population, what the cost is? So we got to really kind of change the system and move towards this value-based reimbursement, software-enabled products that are out there. Because really it's a capitated program, flat payment per patient for chronic disease. And as I said, 50% of all the payments were based on this new model. You're going to need all new technology for this. You think about, I spent all this money getting a product that met meaningful stage 1 and stage 2. That's like going to kindergarten. And now I got to have your master's degree or your MD degree to really monitor the quality and the cost of these patients. These products who are built around stage 1, stage 2 cannot meet that requirement. You need something much stronger to be able to manage the health of that population. So I think a lot of the EHRs out there today will not be able to meet the requirements you're going to need to managing the health of a population, no matter where that population goes within the healthcare community. It's a whole new model I call the next generation EHR around value-based reimbursement.
So with that, this is definitely sort of a sistered question, but more specifically within that technology, not so much even from a hardware perspective, but from a software need perspective, what else are we going to be looking at here in the near future?
Well, you got to think about who the patient is. And the patient that has a chronic disease may be going to 5 or 6 different doctors. They may go to the hospital. They may end up going to multiple hospitals over a period of time. I need a single clinical and financial database about this patient. I need to know all of their clinical information. I need to know all of the cost information, not necessarily the charges, because sometimes charges have no relationship to cost, but I need to know what the charges are, and I need to know what the cost is. I need to have one database for this. Now, that does not mean you're all on the same software product, but a care coordinator who's responsible now for coordinating the care of this patient has to have everything together in one place. Care coordinator cannot be looking at 5 or 6 different computer systems trying to bring this data together. Ideally, everybody's on the same software, one integrated system. That's what the Epic and the Cerners of the world want everybody to be on their product. But the reality is people are going to end up being on certain different products. A specialist that is a dermatologist, endocrinologist, a neurologist needs something different from the traditional primary care doctor. So we're still going to have different products out there. But I need a care coordinator software and services that brings all of the data into one location for managing the population. And now a lot of people have been talking about that in the last couple of years, population health management type software. All that really does is identify who the patients are and identifies who they're seeing, and ideally we move towards a cost model to understand what the costs are. But we have to find ways of going past that to really engage the patient and their family, having the software that really ties the patient in, collecting data from that patient's home, or on a wristband that the patient wears that identifies their blood pressure, their pulse, their respiration, sends that information back, having remote monitoring devices for cardiology, for bringing that EKG information in once a day to a cardiologist to review that. But we also have to bring in best practice guidelines. These are the care coordination items that are going to be needed for that patient. More on preventative care, more doing tests that are necessary to monitor the patient, but not duplicating those tests, having the test done once and having that result available to every provider who's treating that patient, so we can help reduce a lot of that duplicate tests. But then I need to have what's called exception reporting on clinical alerts. Don't send me everything about the patient. If the patient has a high BMI, I already know that. I don't need an alert on it. Tell me when things change. Tell me when the patient's getting worse, that I have to do something today. So it's, don't give me every single clinical alert about the patient. Give me where the patient's no longer in following the clinical protocols. Their BMI got too high or something else happened. Their creatinine level's too high or too low. Tell me when there is a problem so I can react to it today. Don't tell me that 3 months from now that I go back and look at the results, oh, the patient had problems. I need to know today the patient had a problem, and I need to react to that. So if I'm monitoring 100 diabetic patients, tell me the 5 patients that are at the highest risk today that I can do something with. Exception reporting of clinical alerts. But those alerts got to come back into the point of care, because that doctor is going to be seeing other patients. They may be in their EHR. I need the alert to pop up inside my EHR, the product that I'm using. I don't want to have to log out of that, go into another product and find out alerts. I need to know inside the EHR that I'm working with a clinical alert about a patient that tells me I need to do something today for that patient. And then from the financial side, we need financial modeling and risk stratification to help determine which patients are at the highest risk and the highest cost and the lowest quality. Because again, we're going to get reimbursed based on a whole new model of flat fee capitated rate. But we got to find ways of not losing too much money on these patients and hopefully having a profit margin where we can also do other types of patients, other kind of things too. But we need a true financial modeling around cost, not around charges, and risk stratification to make sure we understand which patients have the highest risk. Next. And again, to really do all of this, it's all about bringing all of the information together, connecting everybody, the home health providers, the employers, the patients, the retail pharmacy, the physicians that are out there, the radiology centers, the lab centers like Quest and other companies like that, bringing all that data together into a physician solution, because the physicians are the ones who have to be viewing all this, but bringing all this data together. We got to get away from still having all these silos out there of the information. And a lot of times we see that one hospital has some data on a patient goes to a different emergency room, they have the information, none of that data is being shared. And an ACO is the best position to bring all this data together because they have the right financial incentives to share the information with everybody in that community because they're getting reimbursed based on a capitated amount of money for that patient. So the ACOs have the incentives to bring everybody together and share that information for overall reducing costs and improving quality. Next.
In terms of all that interoperability, I'm still trying to wrap my head around where that value lies when exchanging that data within the community. I know you're ready to address that, so we'll pass it right back off.
Yeah. I think that the challenge we've had over the last 3 or 4 years when we talk about health information exchanges and quality exchange of data, it's all been about sharing of the information of the hospitals with the doctors, sharing of physician data within the hospital setting. That has been the problem out there. And the real value, and the slide's kind of reversed right now, I just noticed, the real value is the 65% of all the value is really on the bottom side, which is the biggest. Sharing of the patient data between providers. Getting the information from the primary care to the cardiologist. That's the biggest box, the biggest value. Sharing of hospital data with the physicians creates only about 10% of the value, the one at the bottom there. It's the smallest percentage because the doctor is taking care of a lot more than that patient's hospitalization. They may have come in because they broke their leg. That has nothing to do with maybe their diabetes or hypertension or other kind of issues. The value is in sharing that data between the providers out there. And that's what we want to move towards, is how can we share data between providers, not just the hospital. Now, getting data from the physician's office to the emergency room creates value, but getting information about that physician's data that they've collected to a patient being admitted to the hospital creates some value, but it's all about sharing the data between the providers. Next slide. And this is what we're really talking about doing. These are just some examples that are out there. You got some patients that are maybe physicians that are using NextGen, some on Epic, some on Quest, and a few on athenahealth. Getting that data to be able to share between them, having the data go from Quest to Epic, from Quest EHR to athenahealth, and sharing all that, because you got to have information about their social, family, and medical information. Medication detail is so important out there. Obviously, having laboratory results are so important because a lot of doctors say, I need the medication, I need to know what their lab results are, and I need to know what their problem is. If I can just get that together, I have a lot of information about the patient. We can bring all of that together, but we have to have two other aspects to that. An enterprise master patient index, which is basically a technology that says this is the same patient. We have too many times, like the hospitals I worked with, we have the same patient listed 5 or 6 different times in the healthcare system. They use their full name, they use a hyphenated name. It was first time it was Joe, next time it was Joey, and when we register them, we don't know they're the same patient. We got to find a way of bringing all that information together so we know it's all the exact same patient and bring all that data together. And obviously, we have to have security and access control. Only certain people should have access to that information. We got to protect that patient's confidentiality about their lab results, about their medications, and make sure it gets to the right person at the right time. But this is what we got to do. We got to connect the providers together, the primary care with the cardiologist, with the neurologist, with the cardiologist, and share information between everybody. That's the only way that we're finding that the ACOs are able to save money, improve quality, is when they're sharing the clinical data between all of these organizations. Next.
All right, Mark, let's talk about some next steps. What's the first thing that we can do to get ourselves ready for VBR in an ACO world?
Well, I think it really gets down to figuring out what you should be doing as far as, are you going to participate and move away from fee-for-service to value-based reimbursement? As a provider, as a doctor, the insurance companies are not going to come to you and say, would you like to participate? They are going to go to the health systems, hospitals with doctors, or ACOs that already have this next-generation technology built for clinicians by clinicians. And they're going to say the contracts are going to go to them. So as a provider out there, you need to be helping lead these ACO organizations about clinical integration, improve outcomes. You need to be involved in these larger hospital systems, also large IDNs, to get involved with them, not necessarily be employed by them, but working with them to figure out how you can be part of that organization to help improve qualities, identify high-risk patients, and reduce costs. Because if you don't get involved in these organizations, they're not going to include you in their physician panels. And if you're not involved in the physician panels, patients that you've been treating for 10 or 15 years could be automatically assigned to a new physician because you're not part of that health systems panel of physicians. You got to get involved today, understanding this. And from a technology point of view, you have to have a technology, your EHR, and your billing revenue cycle management system that can integrate in with whatever that larger hospital system has. As I said, all the contracts are going to large ACOs or health systems. These contracts are not going to individual physicians. You got to be tied in with them and coordinating the care and clinical data between them. Next.
All right. me get the poll up for everyone here. We'll open that. You'll notice the poll has jumped up on your screen. If you would all be so kind as to go ahead and fill out a couple of quick questions for us, that would be excellent. As well, we've had the Q&A section open throughout today, and I have a couple of questions already ready for you, Mark. Thanks so much for all of that information. There's some definite variables ahead here, and it sounds like this trend is definitely sort of inevitable, the freight train moving towards us. Our first question here, we see, do you see changes in the near term in regards to the CMS benchmarks? I feel like too many businesses will be signing up for a losing model to start before they can achieve the necessary stats for savings.
Yeah, so, and that's why, that's why we're, the CMS has gone away and calling, we call it Minifuse Stage 1 and Stage 2. Now they're getting away from that. They have all new standards that are going to come out built around this new Medicare value-based reimbursement model for identifying chronic disease patients. Minifuse Stage 1 and Stage 2 collected a lot of data about all patients. Now it's all about what can we do for these people that have chronic diseases. So a lot of the measurements are going to be changing away from collecting, the race or something about a patient, every single patient. It's going to be more specific to identify patients with chronic diseases and improving the overall quality indicators, basically reporting data on these people with chronic conditions. A lot tougher because a lot of these EHR products were all about collecting data. Now we got to move towards identifying improvements in health, which is partly collecting data, but it's all about show me how I've actually improved the health of this population. EHR's got to get away from being a data collection tool to a quality improvement tool, which most are not designed for that at all.
Excellent. I have another question here. This one deals with perhaps a more sensitive issue. What about the patients that are refusing services due to lack of income or lack of insurance coverage? And I think she's referring to that sort of capitative model as well, but how can you promote a quality outcome when someone essentially refuses the service that ensures that quality outcome?
Yeah, we basically call it compliant patients, and obviously this only works if the patient's compliant with the orders of the physician, their care plan. That's why it's so important to get patient engagement going on and family engagement, getting the family and the patient, the community involved and trying to find ways of improving the overall health of the patient. You're still going to have a big percentage of the patients potentially that have chronic diseases that are not compliant. That's why you have to have a care plan that monitors specifically what the patient has been compliant on and what the patient has not been compliant on. We think in 2018 and 19 that you will get credit, if you want to call it, when patients are not compliant. There's going to be a reporting mechanism on compliant patients versus non-compliant patients. You're going to be measured more on those patients that are compliant. But by 2020, it's going to be more driven towards the whole population of patients. Whether they're compliant or not, it's up to the healthcare provider to find ways of getting that patient more compliant. That's where the family and the community have to come together. You're never going to get everybody, but you got to find ways of getting the percentage of non-compliant patients down. So in 2018, I don't think you're going to be measured that heavily. You're not going to get penalized if the patient is not compliant. You got to be able to measure that. But in 2019 and 20, they're going to be saying you had 20% of your population was not compliant the first year. You got to drop that by 20%. So they're going to be looking for improvements in number of patients that are compliant as a percentage of your overall model that you're following. But it's all about creating care plans and getting the patients engaged. I wish the government or somebody else would put some kind of incentive on these people with chronic diseases that they need to follow the care plan. We think that'll happen with the Aetna, Cignas, and Uniteds, where the insurance rate may vary based on how compliant the patient is. But right now, Medicare is not looking at that as far as we know. CMS is saying it's all patients, whether they're compliant or not, are going to be part of this program. But there's got to be some kind of financial incentive. The compliant patient should be able to get a lower insurance rate than a non-compliant patient. That's what we do with life insurance. If you smoke, you pay more. That's what we do with auto insurance. If you speed or you have a lot of accidents, your rates are higher. But in healthcare, we have that one rate for everybody, depending on if it's Medicare or your employer's rate that they have. we got to find ways of incentivizing the patients so they're engaged on being compliant, as well as penalizing the physicians. It's really got to be everybody that gets involved in this.
Right. We have a number of questions with sort of a follow-up going on with that, with a fair amount of concern over those non-compliant patients, or perhaps providers not wanting to accept certain patients based upon either compliance or those same health risks. Now, I know this is also sort of very crystal ball of an ask, but do you think that some of that burden will fall back again to the insurance companies in terms of, covering or not covering, and as you're talking about a more scaled model as far as the payment system goes and what insurance actually costs? And I don't know if you can speak to that a little more as far as those concerns with providers not wanting to accept certain patients because of those factors.
Well, I think you're going to have a lot of that still going on no matter what. We can't get rid of all of the, the non-compliant patients that are out there. But what's going to happen is the health insurance plan in a certain community is going to say, I've got 500 diabetic patients. Which hospital system would like to bid on those patients? And one hospital will say, I'll do it for $8,000 a year. Another hospital will say, I'll do it for $9,000 a year. Another hospital will say, I'll do it for $8,500 a year, but I'll have these better quality improvements. It's going to be a bidding war for the healthcare system to pick these patients. Once that healthcare system has been assigned those 500 diabetic patients, it's up to that healthcare system then to find ways of working with the physicians, finding the right physicians to work with this population. You may find that a lot of this diabetic patients may go to the same doctors that they had before, but there may be a 10 or 15% of the diabetic patients who are going to get assigned to a high-risk physician who will get paid higher than the other physicians for taking these high-risk patients. The interesting part about all of this, though, it's all about the health insurance plan assigning patients to a health system, and that health system assigning those patients to physicians. What about the patient? Doesn't the patient get a choice on who they see? If I'm used to going to the Methodist hospital system, and all of a sudden that contract by the healthcare plan gets assigned to Memorial Hermann Hospital, I have to now change my hospital that I go to. I have to change the doctor that sees me. To date, I have not heard anybody talking about patient having the ability to select who they want to see. This is all about the insurance plan assigning the patient to a specific healthcare system, and that healthcare system picking their doctors. So I think that's going to be probably the biggest variable out there, is how do we get the patient to be compliant when all of a sudden they may be assigned to a totally different doctor, somebody that they don't want to go see. I don't want to go see the doctor I've been seeing for years. I'm not going to be compliant now. And how is everybody going to work around that issue? Because Obama said originally, if you like your physician, you can stay with your physician. Obviously, that changed a little bit, but this could be totally changing now, where the health plan picks the healthcare system based on who has the lowest cost contract that's signed for those people with chronic diseases. So there'll be a lot of change, I think, going on. But sooner or later, we're going to have to talk about the patient and what do they think about these kind of programs.
Wow, this really does sound like a little bit of a minefield moving ahead, but I know we'll have to find a way to navigate it. We have time for one more question here for Mark before our sponsor presentation. This last one comes in once again with concerns on the benchmarking. So is there anything in the works to extend the emphasis on regional benchmarks versus national? Our practice would benefit greatly compared to other practices in the state, but less so against the whole nation. So that's speaking once again to those benchmarks on the VBR model.
Yeah, I think we're actually moving not away from the national, more towards regional, but really towards local, because the healthcare system is going to be assigned a kind of a national statistic / regional statistic as far as what they have to meet for their incentive program, but it's more going to be the hospital system, which is hospitals and physicians, comparing doctors locally to other doctors locally. Because the healthcare system, remember, these are contracts only for 1 year. So each year, I can either win the contract or lose the contract. Doctors can win patients or lose patients on a yearly basis. I think it should be like a 3-year program, but right now it's all based on a 1-year program. But the hospitals are going to be saying which cardiologists, which primary care doctors are the best positioned to help us meet our quality indicators. So they're going to be comparing local doctors to local doctors to see about quality and cost. And part of this is going to be is which doctors can improve quality by reducing ancillary tests down. Don't order 300 lab tests. Only order the ones that are necessary to be able to improve the quality of this patient's livelihood for this chronic disease patients. So I think it will be more local comparison, but the hospital is still going to be measured based on regional and national numbers. The hard part for the hospital is if I have 10 different contracts for diabetic patients with 10 different insurance plans, all 10 will have different quality indicators that they're going to pay on. And how does a hospital monitor and maintain 10 different quality indicators? And to help the physician meet those requirements, you know, how are they going to tie all this together? Because I don't want a doctor have to treat patients 10 different ways because 10 different healthcare plans have different quality indicators. We got to find a way of creating the best care plan, the best clinical alerts that drive the best benefits to everybody without creating 10 different programs for the doctors to try to follow. They have to have one program for the doctors to follow, and we got to move towards that kind of model.
All right. Well, thank you all for all the questions. If there are any that continue to come in or any that were unanswered, we'll be sure to follow up with you all directly after the session. And we now turn our attention to Ms. Bobby Abbott of Care360, who will provide us with a brief overview of their solutions. Bobby?
Thank you, Colby. And thank you, Mark, again for sharing your insight and your expertise with us. It's always great to welcome you back. I'm going to just shift gears for a moment and spend just a few minutes providing an overview on Care360 and discuss how we develop and deliver our technology solutions focused on increasing efficiency so providers can focus on the health of their patients. Quest Diagnostics and Care360 do connect you to the larger healthcare community. We are a Fortune 500 company focused on improving the health of patients through our diagnostic insights and using those insights to drive action. Care360 is the healthcare IT division at Quest Diagnostics, and together we connect more than 420,000 physicians in over 125,000 locations with our collective solutions that I'll speak to in a couple of minutes. As our map illustrates, we have a broad-reaching footprint in the U.S., and we're a valued and well-known brand in the healthcare market. Our Care360 Solution Suite offers a holistic, streamlined approach in supporting healthcare practices. Initially, we started with our Care360 Labs and Meds solution that was designed to help ambulatory physicians place lab orders and review results electronically. We then shifted gears and introduced our e-prescribing that was developed to allow physicians to write and manage prescriptions electronically. Our e-prescribing does indeed offer a DEA-certified electronic prescribing of controlled substance functionality. In addition to e-coupon, it's a value-added solution that integrates manufacturer incentives into our product. So really, at the click of a button, providers can extend those savings electronically to the patient's pharmacy. And we have just developed electronic prior authorization, so embedded within e-prescribing and our EHR, physicians have the ability to electronically submit prior authorization, which saves them time and money ultimately. And we have our MyQuest Patient Portal, which just topped 3 million registered users. So our MyQuest Patient Portal supports secure collaboration between the patient and the physician, so it really opens that avenue to collaboration between the entities and allows for things as sharing lab results, scheduling appointments, and various other communications that take place between the provider and their patient. And I'm going to just spend a few minutes now talking about our Care360 electronic health record. Our electronic health record is a cloud-based offering, and it's designed truly to enhance quality, productivity, and patient outcomes. Folks can access their records, their patient records, anytime, anywhere with an internet connection. And our electronic lab orders and results and e-prescribing are accessible directly from within Care360. You can rely on secure mobile access anytime, anywhere. And at the end of the presentation, Colby will illustrate how to access our demo app so you can access Care360 on your iPad and just get a feel for how it works from a mobile perspective. Our Care360 practice management solutions allow you to efficiently manage the flow of patients, potentially increasing revenue, improving productivity, and increasing patient satisfaction. Our solutions include a dashboard view to maintain a clear picture of your practice's performance. And knowing that each practice is unique, we do offer customized scheduling and reporting to meet your specific needs. Patient records are always readily available, and our solution helps drive efficiency through automated appointment email reminders. And if you have an EHR that you're currently happy with but need to implement a practice management solution or feel like you need a change, you're still able to use Care360 practice management with your current EHR. Our Care360 revenue cycle management solution, rather service, rounds out our Care360 solution suite. If you don't have bandwidth or resource to manage your billing, we can manage it for you. We do provide a team of expert billers that will handle all of your billing-related needs, from billing claims to collections and denial management. Denials are also worked thoroughly and continuously until they're resolved. Our revenue cycle management solution is, of course, fully compliant with HIPAA, OIG, and ICD-10. And when you choose Care360 revenue cycle management, it does include practice management and EHR within the fee. So it's truly a pay-for-performance model. You just pay a percentage of your collection. And again, our revenue cycle management billing service is available as a standalone service. So if you do have other components of your practice that you're happy with, but you do need a billing solution, you can choose our solution to help round out your practice needs. I wanted to just take a moment to talk about community reach. We know the importance of coordinating care to and from anywhere. Our solutions stand far beyond the ambulatory space and allow you to coordinate care and share data across and within your healthcare community. Given our broad reach and our robust technology, we're able to integrate providers and technologies across the landscape while supporting and sharing insights. And through our solutions, you can indeed send patient information in a CCDA industry standard format, accept information from other providers, and access extensive patient lab history to help optimize care. In addition to our community reach, we have solutions designed specifically to support ACOs by creating a bridge to exchange patient data between an ACO's quality management system or a system that they currently have in place with Care360 EHR. All of that with a focus on identifying and closing gaps in care. And when you invest in Quest, you're investing in a true partnership. As I mentioned, we are a Fortune 500 company, and we work hard to excel at meeting your needs. In 2015, we experienced $7.5 billion in revenue, so we are financially stable. And we do service over 30% of American adults every year with our solutions. Our solutions are easy to implement, whether you're implementing our holistic solution set or parts of it we can implement into your current landscape. And we do have a very robust world-class support team behind you, so rest assured we'll take care of you when any of your needs arise. And I'm going to leave on this last slide. CLAS is a third-party research company that focuses on healthcare technology. Between CLAS and Black Book, we do continue to get anonymous surveys in through these folks. And here are a few comments that speak to our solution, the ease to deploy, ease to use, and integration of our EHR and PM.
All right. Well, thank you so much, Bobby.
Sure.
If any of you in the audience have questions for us about Care360, Bobby is here, as well as Ken Miller, who is the Director of Product Management for Care360. Feel free to use that built-in WebEx Q&A functionality as you have before, and we'll get to them right away. We do have one that came in early. We said you mentioned the ability to integrate with ACOs. Could you please elaborate on how that works? I think we could lob that one over to Ken, actually. Ken, are you available?
I am. Thank you. We have a couple of different ways. We've got an enterprise approach to allow our Care360 application to integrate with a health population or with a care coordination application. And it's the ability to use both what's called single sign-on capability to allow a physician that might be looking at those applications to jump right into our Care360 application. It also permits that when a patient is looked up, that patient is transitioned between the two applications so that when you're wanting to work with one patient, you can easily and efficiently do that. We also have several different analytics approaches, as Bobby had mentioned earlier. We have some more defined formats that we use to be able to send data daily back to those population health or care coordination applications to make it, and again, an enterprise level type application that keeps both systems up to date ongoing. So a lot of good work has taken place here to complete these analytic solutions.
Outstanding. Thanks, Ken. With respect for everyone's time, we're going to cut the Q&A a little short. If any other questions do come in, as I said, we will follow up with you directly after the session. I did want to mention that you can grab your iPad and go to the App Store and download the Care360 HD app. And once you download it, if you use the username demo and the password demo, you'll get a fully functional walkthrough that you can go ahead and take good advantage of and get a good look at our application. I think you'll find it rather intuitive, actually. Do give it a shot if you have a moment. With that, I thank you all once again. Thanks for your attendance and your participation in the poll. I need to put that poll results up for you. Do that really quick. And then with that, we also want to thank our presenters and our resident experts for joining the call. We sincerely hope that you enjoyed the presentation. Please do keep an eye on your inbox for future webinars and content from Care360 and from Mark Anderson. Thank you all once again, and this concludes today's presentation.
Healthier outcomes are now easier to embrace. We know you run a busy practice, and efficiency is top of mind. Discover 360 degrees of connection and support. Keep your practice on solid ground with a cloud-based EHR.
Care360 offers a full and fully mobile EHR that helps keep medical practices efficient and profitable,
while connecting to the larger healthcare community.
Join the network of over 300,000 Care360 providers in 90,000 locations and connect to other healthcare providers as well.
Coordinate care to and from anywhere.
Care360 integrates providers and technologies across sites and care settings,
while seeing and sharing the bigger picture.
Care360 allows you to send patient information using the CCDA industry standard format, accept information from other providers, and access extensive patient lab histories to help optimize care.
Meet meaningful use requirements.
Care360 EHR is ONC certified to qualify for meaningful use,
while exchanging data simply and securely.
Physicians collect and share data with other EHR users to meet industry requirements with Care360 Data Exchange.
And with new Care360 Revenue Cycle Management, you can maximize collections and revenue.
Care360 provides you with a team of billing experts to take complicated billing issues off your plate, allowing you to focus on what matters most, your patients,
while reducing your administrative burden. And that means more time with patients. Care360 also offers many other great advantages. Boost patient engagement and compliance with MyQuest.
Patients can view and share vital health information with their healthcare providers.
Elevate patient conversations with interactive insights.
Enhance lab results with diagnostic insights, accessible in Care360 and to patients through the MyQuest patient portal.
That's 360 degrees of connection and support, and healthier outcomes for all. Care360.